So where are we now in 2023? We have comprehensive training programs that train OBGYNs who are already fully trained OBGYNs to become reproductive endocrinology and infertility physicians. Now, I said reproductive endocrinology and fertility physicians. That is very different than training an IVF physician.
Who the heck is going to pay for all this? Today, we talk about REI Fellowship programs and REI Fellows, answering those two questions because they're not exactly the same question. The question of how you get more REI Fellows isn't necessarily the exact same question as how you create more fellowship programs, but we do talk about both of those questions. My guest is Dr. Rachel Weinerman. Dr. Weinerman did her fellowship at Penn. She's been at university hospitals in the Cleveland area since 2015. She's been their program director for the fellowship program there since 2021, and she's got some ideas. First, I kind of poke at her for a little bit, and I make us spend some time on this question that we've talked about a lot on this show, which is what does an REI need to be doing versus what does the IVF specialist need to be doing? Because very often we approach that question from the other way. The way we usually approach that question is how much REI training does an IVF specialist need to have? So I tried to take that question from the other way, and I made us spend some time on it, even though it isn't the main topic of this episode, because I wanted to try to isolate how important is the scarcity of REI Fellows if the volume question isn't at play. If technology solves for a big chunk of the volume question, is the lack of REIs still a problem? I wanted to isolate that, and I think we did successfully. Then we started to get into the steps of setting up an REI fellowship, starting with the roles. What's ABOG's role? What's ACGME's role? We talked about ACGME rules. We talked about Medicare rules. We talked about what Medicare pays for, not a lot. And then we talked about what the institution pays for, and that got us in more to the costs of running an REI fellowship program. The REI's salary, their insurance, their malpractice, their benefits, paying for program coordinators, paying for other conferences, training, capacitation, and other professional development. Finally, we talk about who's going to pay for all this and what are some ideas. Ideas including allow REI fellows to perform those services for which they can bill up to the capacity for which they're allowed to bill. National organizations like ASRM and SREI possibly contributing to a fund, and things those national organizations can do beyond just funding, like standardizing a didactic curriculum, suggested rotations. And we talk about this trend of Privademic partnerships, but also their limitations. Why have we only seen some of them and not an explosion of everyone doing them? Everyone seems to agree that we don't have enough REIs coming out of fellowship, regardless of where they stand on how much REI training they think IVF specialists need. I've never had anyone argue the opposite, that we have too many REI fellows or that we don't need more. If you do have that viewpoint, you're welcome on the show. But this is a problem that everyone seems to have consensus from, that I can tell. And so I hope you enjoy Dr. Weinerman's insights on why this is happening and what we can do. Dr. Weinerman, Rachel, welcome to Inside Reproductive Health.
Thank you. It's a pleasure to be here.
You were a profile of person that I wanted to get to know, that I am glad I've gotten to know this year, because I really am interested in how the REI Fellowship works, how we get more of them, what's necessary, what's not necessary, because I'm not a clinician. I don't have a dog in this fight of that we should be training OBGYNs to do A and REIs don't need to be doing B. I can't really opine. I can only facilitate the conversation, try to pull in as many points of view as I can. You are a bit more qualified to opine. And so I want to start with let's start with the importance. What are the important things in your view that REIs learn in fellowship that can only be learned in REI fellowship?
Yeah, great question. And thank you for having me on the show. I want to start by saying that my opinions that I express are my own. I'm not representing any official organization within the world of REI. I am the program director, so that makes me, I hope, qualified to discuss this topic, but I'm really sharing my own opinions. So first of all, let's think about what is the history of REI training. So REI fellowships have existed since the 1970s, and they've evolved and adapted. In 1974, when the first board exam was given in REI, IVF didn't exist. So what we've done in training our REIs has obviously evolved, in the last 40 plus years. So where are we now in 2023? We have comprehensive training programs that train OBGYNs who are already fully trained OBGYNs to become reproductive endocrinology and infertility physicians. Now, I said reproductive endocrinology and fertility physicians. That is very different than training an IVF physician. Because what we're trying to accomplish in an REI fellowship is to train subspecialty physicians who are experts in reproduction, who can serve as consultants to general OBGYNs and other physicians, and who can provide comprehensive clinical care in infertility and other reproductive disorders, as well as innovate and move the field forward so that we are constantly improving our knowledge and what we can do for our patients. So I would say that's the overview of how we frame our fellowship training. And I think that really informs what we do in a fellowship.
So how much of a rabbit hole do I want to go down now? I guess we'll touch it a little bit, where someone who is doing IVF doesn't necessarily need to be an REI. Or are you simply making the distinction that REI is a lot more involved than just IVF?
I would say the latter. I think that currently the way that we structure IVF practice in this country, and we can discuss whether that's going to change in the future or not, in order to practice IVF with the full depth of the field, you have to be trained as an REI physician. An REI physician doesn't just do IVF, but the knowledge that you get, the depth of experience that you get informs your ability to provide proper care in IVF. To put it maybe a little bit more specifically, the way that I train my fellows, I want them to be able to be creative in how they provide IVF care. I really don't want them to practice algorithmic medicine. And in order to do that, you have to understand the basic physiology. You have to understand what's happening at a molecular and cellular level in order to make decisions that best account for the information that you're getting in real time.
Is that at odds with an operational scaling system? I had one guest, a CEO from a fertility network in India, that episode will almost certainly have aired before this one does. And he was speaking about their network has one set of protocols. There's one protocol per patient profile, and they have, I think, 250 physicians. Now, there isn't an REI fellowship in India, so these are OBGYN physicians, but they have 250 in their network, and they're all practicing from one set of protocols. And I said, I've worked with 2 doctor REI groups in the US that have different sets of protocols. And so is what you're saying, where you don't want your REIs necessarily practicing algorithmic medicine, is that at odd with the scale of operations of something like having one set of protocols?
That's an excellent question. And I think this gets to one of the biggest questions within medicine is, do you practice based on what we call standards or algorithms, or do you practice based on individualization? And I think that, in America, we have excellent outcomes in IVF. Obviously, they can always get better. And what accounts for our excellence? Well, there's many things, but I think one of them is our ability to provide high quality and individualized care. Now, that's different, right, in large practices versus smaller practices. And you might say that large practices do have more of a focus on standardization, which is another word for algorithm. But when you have physicians that have that in-depth training, they can pivot. So the way that I tell my fellows is, you can do the first cycle as an algorithm, right? But if that first cycle is successful, great. But if that first cycle is not successful, what's going to be your next step? How are you going to pivot and change your treatment plan to account for what happened in that cycle? And that's very difficult to create algorithms that account for each situation that you might encounter.
So that's on the side of how much REI training should IVF specialists be able to have, or at least be involved in. How much else should REIs be doing beyond IVF? So I'm thinking of the question this way. When we have David Sabler, a number of others on, will say we're doing about 250,000 IVF cycles in the US. We need to be doing somewhere around 2 million, perhaps more than that. And so that is to suggest that we need more IVF being done. But if there are other ways of being able to scale IVF, what else should REIs be doing beyond IVF?
That is an excellent question. I don't think I have all of the answers to the scalability question, because I think that might entail a significant reimagining of how we provide care. So I think that's an excellent question. I don't think that I have a very specific answer to it, because I think it's a really philosophical debate about how do you provide infertility services and IVF specifically. What a reproductive endocrinologist is trained to do, and we were able to do after fellowship, is provide comprehensive care. So that means that if a woman comes with irregular periods, with abnormal reproductive hormones, with fibroids, with malaria abnormalities, all of those can be addressed in a way that allows her to proceed with her reproductive goals. So that is what a reproductive endocrinologist can do. Can that be broken up from IVF? Again, I don't know the answer to that question specifically, but you can't provide full comprehensive infertility care without those additional areas.
What distinguishes REI trained doctors from other physicians in the field of infertility?
Yeah, great question. So I'm going to assume that what you mean by other infertility physicians are OBGYNs.
OBGYNs or, almost certainly OBGYNs, or I guess advanced practice providers working with OBGYNs.
Right. So those are two different categories. So advanced practice providers typically have 2 years of schooling after college, and then they don't have any formal clinical training after they graduate their program. So a lot of knowledge gained by advanced practice providers is going to be in the clinical setting on the job, what you might think of as an apprenticeship. And they are trained for the clinical work that they'll be doing, but specifically by who they're working with. So their practice styles may change. And then the depth of knowledge that they have is obviously different. An OBGYN will have completed 4 years of medical school and a 4-year residency in OBGYN. And they have, a significant more depth of knowledge. Their experience in REI specifically may be more limited. Most OBGYN residencies require at least a month of REI training, but sometimes it's only a month. So that's, they obviously have expertise in many areas within OBGYN, but they may not have that depth of knowledge to be able to practice infertility. And a lot of that learning that would be necessary if they were to practice infertility would have to come after training.
I'm thinking there's a few fertility center practice owners that I can think of that were sort of grandfathered in prior to fellowship requirements that never had an REI fellowship. And then there are others that I can think of that work in fertility practices. They work with and under an REI in many cases, and they have for years, but they never had a fellowship, and so I don't believe that they're board certified, because you need the fellowship in order to take the boards, right? You can't.
Yes, and I can go over that in more detail for you. Yeah.
This question of, okay, you have some docs that were grandfathered in, and you have other docs that maybe they weren't grandfathered in, they're still working with REIs, but they've been doing it for 15 years. And so what does an REI fellow have? What does someone gain in REI fellowship that they might not have gained?
Well, first of all, it's a great question. We do have doctors who are grandfathered in. I would say many of them are older, pre-board certification for REI, although that is tending to be phased out. 15 years is a lot of experience. I would say a lot of OBGYNs working now may not have that length of experience going into an infertility practice. But let's talk for a minute about what REI fellows do in fellowship. Currently, fellowship is 3 years. In the past, it used to be 2 years. There's some discussion about whether that length should change. Fellows they do at least 18 months of clinical rotations. That includes training in infertility and what we call ART, not just IVF. They do surgery, they do genetics, they do male infertility, endocrinology, pediatric endocrinology, and increasingly spending time in the IVF laboratory learning IVF techniques. Then they spend at least 12 months doing research, and that research culminates in a thesis. It's called a scholarly thesis that has to be presented. And it represents a significant scientific effort, which demonstrates knowledge not only of the scientific literature and the scientific method, but how to critically appraise what is happening in the world of scientific knowledge within REI and how to innovate in that field, that they've demonstrated by doing that type of project. And then they typically also have 6 months of electives, which can be individualized to the fellow and their training requirements. So that's the overview of what they do. In order to then actually practice within the field of REI, they have to take an exam from the American Board of Obstetrics and Gynecology. It's actually 2. They take a written exam called the qualifying exam, and then they take an oral exam, which is the certifying exam, after they graduate. They collect cases for 12 months and submit their case list along with their thesis in order to sit for the exam. And then they take the exam, which is a 3-hour oral exam.
So there is a breadth that people are learning in the REI Fellowship program. And that takes me back to the question of what else should REIs be doing? And I thought of a different way of asking the question. So if we're doing 250,000 IVF cycles or so, we should be with 1,200 REIs and plus probably some others, because that almost certainly includes OBGYNs who are part of that process. But let's just say we've got 1,200 REIs in the country right now doing 250,000 cycles. If with technology, with training other docs in other positions, massive operational improvements in the next 10 years, we are doing 2 million IVF cycles from 1,200 REIs or even fewer. What I'm saying is right now, a lot of the argument for increasing the number of REIs is because we need to meet the demand. And let's just pretend that we can meet the demand with the improvements that happen over the next 10 years. Do we still need more REIs then? If we can meet the IVF demand, do we still need more REIs? And if so, what for?
So I would answer with a resounding yes. I think we need more REIs. And I think what I'm describing about REI fellowship and the intensity of fellowship and the value of fellowship doesn't change the fact that we don't have enough REIs. And we can talk a little bit about some of those impediments, why we don't have as many REI fellowships as we do. How do we train more REI fellows? In the end, in order to practice quality medicine, you need more REIs, even if those REIs are supervising, say, advanced practice providers or other physicians that may not have REI specialty training. In order to scale up as significantly as you're describing, you would still need more REIs in those roles. They may not be always providing the direct care. Like they may be supervising other providers. And I would say that that's an appropriate role. But if you don't have an REI involved in that supervision, then likely the quality of care will not be what we want it to be, and the innovations won't occur.
Is there anything else beyond supervising IVF? Is there more research that needs to be done? Are there other areas of medicine that the REIs should start to be, I guess, I don't know what the word would be, cross-disciplined with? Is it beyond supervising to meet that scale? What other responsibilities should the REI take on if AI and all of these other technologies and systems do in fact? And I understand that's a big caveat, but fiat that me for a moment. And what else should they be doing?
So let me put it to you this way. There's a debate within the world of REI as to how much that E should be there, right? REI is reproductive endocrinology and infertility. How much should the REI focus be on endocrinology? That's historically what the field was. Again, before IVF existed, a large role that the REI had was in managing hormones. Now we still do, but that looks different now that we have ART as a huge component of what we do. So should that E be replaced with, for example, a G for genetics? A lot of what we do now involves very complex genetic information, both from the perspective of the patient and the patient's partner, and from the perspective of the embryo. And the information that we're getting is enormous, it's complex, and it's changing. So to be able to adapt to care for patients in this changing environment, that is an area of focus that REI might consider in the future. The other question is gynecologic surgery. And that historically has been a very important part of what REIs do and is still a very important need. There are many patients whose fertility needs cannot be solved with ART alone. They need surgery in order to be able to accomplish a successful pregnancy. And that historically has been the role of the REI. There are now more minimally invasive surgeons within the world of GYN who do some of that surgery. That, I would say, is an open debate. There's many different opinions. I personally work at an institution that is very surgical heavy, and we are able to provide that type of comprehensive care for our patients. So I would say, what else could REI be doing? I would say those are two areas that I would say we have to think about how much we want REI involvement. And then I would say what you mentioned about research is extremely important. I used the word innovation before, and I think that to me, research is a prerequisite for innovation. If you don't have people trained in being able to perform research and assimilating all of these types of complex data, you will not see innovation in the future. You will not see improvements in pregnancy rates. You will not see improvements in what we are able to provide. I mean, I don't know what IVF is going to look like 40 years from now. I hope it looks very different than what we're doing now. I always tell my patients, I have to give them the option of donor egg, for example, now because they don't have, any egg reserve to be able to get success with autologous IVF. I hope that's different, by the time I retire.
The reason I kept poking at that is because I said at this kind of nexus where there are a lot of venture capitalists and private equity people, as well as fertility practice owners and doctors, and so and see them come together, and I see them having conversations. A part of one of the conversations that is coming from the doctor end is, well, what do we do if AI is really able to scale us up to this level? If other doctors are able to do these procedures, if we're able to use technology and systems to answer a big chunk of the volume question, then what is it else that we do? And so where your mind went with that is the answer that I've been looking for to that, is because there's going to be something for you all. I try to tell the REIs, don't freak out. It's going to be different. I think you're going to be doing just fine no matter what happens, but I think it will be very different 10 or 20 years from now. And I'm neither a clinician nor a futurist, so I have to pull it out of, I have to make people like you speculate in order to try to paint a picture. In that, you started to talk a little bit about why we don't have enough programs. And in my view, I'd say we don't have enough. We recently, Inside Reproductive Health, wrote an article. The journalist interviewed you. She also pulled up some numbers on the number of programs. And I think according to the National Resident Matching Program, there were 49 open fellowship positions in 2022. And I want to say that was like from 41 REI fellowship programs, according to that same National Resident Matching Program. So why isn't it enough? Why don't we have more?
Excellent question. I don't think I have all of the answers to, why don't we have more, but I can begin to explain from our perspective now, maybe, what some of those answers are. And I would say that the answer to your first question is we do not have enough. And I think that is a consensus, I would say, among most REIs. We need to be training more fellows to be able to provide high quality infertility services and REI services in the future. Why don't we have enough? So let's start with a little bit about how fellowships are structured, who pays for them, and I think that might answer some of the questions. So first of all, infertility fellowships are under the rubric of what's called the ACGME, the Accreditation Council for Graduate Medical Education, and ABOG, which is the American Board of Obstetrics and Gynecology. So those are long names, but essentially ACGME accredits programs, allows them to function, and then fellows are certified by ABOG. So those are the two organizations that are in charge. In order to be an ACGME approved fellowship, there are a lot of requirements. In fact, I just looked at the program requirements before our session today. There's a 56-page document of everything that a program has to do to have a REI fellowship. That includes being under the rubric of a sponsoring institution that has an OBGYN residency. So you can't have a fellowship without being embedded in an OBGYN residency, which is essentially most likely either an academic institution or a large institution that can sponsor that. And you need to have a program director who has dedicated time, program coordinators who have dedicated time. You have to have ancillary services in many other specialties: medical endocrinology, pediatric endocrinology, genetics, male infertility, full operating room, full hospital privileges, access to the medical literature. I mean, the list goes on. So you can imagine that this is not an easy thing for lots of institutions to do. And it takes about 2 years to get a fellowship up and running. And then the second question that I alluded to was, who pays for this? Because it's expensive to run an REI fellowship. Fellows typically cost somewhere between $100,000 and $150,000 a year. Some of that money comes from Medicare. Actually, Medicare pays through direct and indirect funding to hospitals. But the number of fellows or residents that can be paid for through Medicare is actually capped. And those numbers were capped based on 1997 trainee levels. So it's very difficult to get funding from Medicare for a new fellowship. And so often that funding comes from the sponsoring institution, whether it's the hospital or practice. And it makes it challenging because fellows actually can't bill for their time. So you're training a fellow, but that fellow is not going to make you money in the short term because fellows have to be supervised and you can only really bill for the time spent by the attending physician. So they're not making you money. You're spending money on them. It's an investment, but it's not an investment that everyone can do. So I'd say the combination of the logistics of running a program and getting it off the ground, the requirements, which are significant in terms of what the ACGME asks for in a program, and then how to pay for fellowships are some of the contributing factors.
And when you say it's an investment to train fellows when they can't bill for time, it's an investment, but very often it's an investment for someone else, isn't it? Like
It is.
You're the one training them, but in many cases they're going to go work for someone else. They're going to go move to whatever part of the country they wanted to go to, or people do stay where they went to fellowship sometimes, and there is perhaps an increase happening. I don't, as we see more of the private academic partnerships, but of people staying at least within that organization. Maybe I suspect that there is the limitation in not being able to have more private partnerships. The reason I ask is because when you say they have to have an OBGYN residency, well, almost every teaching hospital does, no? Or am I, I think of the University of Buffalo, I think of places like Stony Brook, Binghamton, and University of Arizona State. They all have medical schools and OBGYN residencies. I believe almost every place that does that has a teaching hospital has an OBGYN residency program, right? So it seems like there's still a whole pool in that group that could qualify. Is it that people that don't have that partnership with an academic institution that can't bring on a fellowship program for that reason? Is that the limitation?
It's one of them. So yes, there are many OBGYN programs out there that do not have attached REI fellowships. I mean, right, there's only 49 fellowships. There's a lot more OBGYN residencies. But if you are a very high volume private practice and you think, hey, I need more fellows, let me open up my own fellowship so that I can train fellows, have them stay on, hopefully, in my practice and build my practice that way. You then have to seek out an institution that has an OBGYN residency to partner with in order to accomplish that.
How much infrastructure is required for that? Because I can think of smaller practices, maybe 2 to 4 REIs, that are in the backyards of a lot of these hospital systems or medical schools. They do have OBGYN residencies. Why can't they? It seems to just be right now be the larger institution. Can you talk to us a little bit more about what else would go into the infrastructure that would stop a smaller practice group from linking up with a hospital system?
Well, I think that if you have willing partners, you can do it. I don't think that there's a lot of hurdles necessarily to a smaller practice linking up with a bigger hospital system if there's a willingness on both sides. The hospital then may want their residents to rotate with that practice. And by the way, every OBGYN residency program has to have a relationship with an infertility or REI division because it is a requirement of their OBGYN residents to rotate on REI. So I'd say most OBGYN residency programs do have a relationship in some form with an REI program, either whether it be IVF or an academic REI division. So I don't know that that's necessarily the hurdle. I think the hurdle is that it takes time to train fellows. It takes time to set up the fellowship. It takes time to run the fellowship. And there's not a lot of financial incentive for that practice to pay for that fellowship unless they know that they are going to be successful in recruiting and retaining their fellows. And in the past, that was actually, I would say, a negative, right? People didn't want to retain fellows. There was not enough spots. They didn't want to train their competition. Now, obviously, we're in a significantly different situation. So maybe we just need to catch up to that. But I think that the amount of time and the amount of money invested is an impediment to small practices who may not be able to devote those resources.
Do you think, I'm making you think on the spot because I'm just hatching this idea in my brain right now, but the debate that goes back and forth about how much OBGYNs should be allowed to do versus how much REI should be able to do. If you were allowed to bill for fellows because OBGYNs were allowed to do either certain parts of the procedure or they were allowed to bill at the same rate or that's beyond my pay grade of the knowledge that I have in that area. But if it were the case that OBGYNs were able to bill more at what REIs are able to, and maybe they are already, but if that were the case, would that then allow for fellowship programs to bill for REI fellows? Has that ever been discussed? Am I not thinking of something else? Is there something unethical in there that I'm missing?
So great question. And no, it is not unreasonable to think about. In fact, one of the challenges that we have now within REI fellowships is we have to think creatively about how to get more fellow spots. I would say most fellowships in the country probably have the capacity to train more fellows than they're currently training. So I know that's true in my fellowship. I train one fellow a year. I could easily train 2 fellows a year, double the number of fellows that I'm training. I could probably even train more than that, based on the volume that we do in both REI work, IVF work, and surgery. The main reason that I can't, there's 2. One, you have to get approval from the ACGME. But assuming that you can do that, it's the funding. How do you pay for those extra fellows? So that's something that everyone I think is thinking about that now. I'm thinking about it. There is one slight impediment to what you're discussing, which is the regulations that govern what an ACGME approved fellow can do. So within an OBGYN fellowship like REI, fellows can bill independently for 4 hours a week in their primary specialty. So a fellow could, do GYN clinic, pap smears, irregular bleeding, anything that is not part of REI training, they can do for 4 hours a week. And so I think that is an idea, is have fellows bill independently during that time. And then that'd be enough actually to pay at least part of a fellow salary or all of a fellow salary. So I would say that yes, that is a good idea. There are some limitations to it, but if done well in a way that is respectful of what the fellow is there to do, which is to be trained, then that might be a way to allow more fellowships to have additional fellows or to allow new fellowships to start.
That up to 4 weeks in the specialty that they are already board certified in, that they're allowed to bill for, is that too much of a distraction to their current fellowship? Would that take them away from what they're supposed to be training for in the first place?
Right. So 4 hours per week, just to be clear on that, is what the ACGME specifies. Now, I mean, that's a philosophical question. Personally, I think that if you're allowing more OBGYNs to train as REI fellows, I think that half a day a week is reasonable. So I think it probably would not detract significantly from the fellowship, and I think it would allow more fellows to be trained. So I think that's that is an idea that, I'm thinking about incorporating into my own fellowship.
So it's ACGME that makes the ruling that fellows are not able to bill for the subspecialty that they're training for. Is that?
It's Medicare rules. So because Medicare is paying for resident and fellows, what we call trainees, then they can set guidelines in terms of what fellows can and residents can bill for.
And is this true for all fellowships? This is true for MFM? This is true for fellowships outside of OBGYN?
Correct. This is true for all residents and fellows in the country that are under the auspices of the ACGME. Now, what ACGME specifies for REI specifically is how many hours an REI fellow can work in OBGYN, what they call their primary specialty.
So I've never actually compared the lack of fellowships in our view to that of other fields. Is every subspecialty or almost every subspecialty having an issue where they feel that they're not able to produce enough fellowship programs or train enough fellows per fellowship program? Or how unique is this to REI?
I think it is somewhat unique to REI. There are, most other specialties outside of OBGYN have larger fellowships. They might train 5 fellows a year, 8 fellows a year. REI fellowships were set up in the beginning almost more like apprenticeships. And so having one fellow became the norm, for each program. I would say that's not necessarily the case for other fellowships outside of OBGYN. Within OBGYN, it is more similar in the sense that most OBGYN fellowships don't have more than 1 or 2, maybe 3 per year at most institutions. But the number of MFM fellowships, GYN oncology fellowships, female pelvic medicine fellowships have all increased much more significantly than the number of REI fellowships.
The reason I ask is because perhaps if this was more endemic to all fellowships, then there would be more likelihood of perhaps Medicare adapting rules to say maybe you could bill partially for whatever it might be, but it's less likely to see any type of change from Medicare if it's just the field of REI or only a handful of fields that are having this challenge. So can you talk to us a little bit about the specific costs? And probably by the time this episode airs, we will have ran another article where the same journalist did a follow up to the first article talking about setting up REI fellowship programs, and it was very difficult for the journalist to button down some costs. And we had some quotes from your colleagues to talk about a little bit of what goes into the variables of those costs, but try to walk us through that as best you can. Variables be damned.
Right. So I would say, first of all, fellows, they don't make a huge salary, especially given the level of training and what they could be making if they were, working in independent practice after they graduate from an OBGYN residency program. But typical fellow salary is probably somewhere around $75,000 a year. So that's a direct cost. Then you have the cost of benefits, health insurance, malpractice, which is paid for by the institution. You have costs associated with the program, for example, paying for the program director's time and the program coordinator's time. There are resources that you need in order to have that program, such as access to the medical literature. So if you're in a big institution, academic institution, which a lot of programs are, then that's not necessarily a problem. But if you're in a smaller institution, that might be an additional cost. And then you have the cost of fellow education. So you are paying for fellows to go to conferences. You may be paying for your fellows to get a master's degree in clinical research or translational research or public health that includes tuition. And then you are also paying for additional educational resources for your fellows. So I would say that's how the costs can add up to over $100,000.
And so in your view, what do we need to do in order to be? Are there things that can be done right now to get more fellowships online? Does it all lie with the institution having to figure out a way to pay for it? Are there things that we can do right now to get more fellowships online?
Yeah, great question. So I would say again, this is my personal opinion, but I think that in order to get more fellows, right, which is different than more fellowships, I think that we need to think creatively about how to pay for a fellowship. And I think that one of the ideas, having sponsorships by, national infertility organizations or private organizations to fund individual fellows or individual fellowships would also be, a great way to immediately get more fellows. How to get more fellowships is to lower the hurdle for entry. Now, that has to be done in a very conscientious way, because if you're lowering the hurdle, significantly, everything that we talked about for why REI fellows are trained in a way that is unique and important for the field are not going to exist. So you have to lower the hurdle in a way that maintains the quality of the education. And that can be done by, for example, saying that we are going to provide resources for program directors to, maybe have a way of submitting their application without spending hours of their time reinventing the wheel. It might mean, lowering the administrative burden, which the ACGME is already working on. It could also mean providing standardized resources from national organizations that can be almost like a toolkit. Here's how you start an REI fellowship. Here's a didactic curriculum. Here are some common rotation goals. So that way someone can say, okay, great, I want to start an REI fellowship. Here's how I do it. I think that's a big challenge right now. And I think that making a more systematized way that we can provide support for organizations to start a fellowship, in addition to financial resources, I think would be very important. And we could do that soon. We could do that and probably increase the number of fellows immediately. Fellowships, like I said, takes about 2 years once you apply in order to actually see that come to light.
When you mention national organizations, are you referring to the ASRM, SREI? Who are you referring to?
I would say those are prime examples of who could provide that oversight. SREI is the national organization that provides oversight for the fellows. So I think SREI is a great organization that can help with some of these proposals that I'm suggesting, which are more, a more standardized approach to starting a fellowship or the resources to run the fellowship.
And so when you say, so if they were to include, if they were to help pay for some of these resources and pay for more fellows to come in, many of those organizations get some of their funding from sponsors. Is there any kind of legal framework that you're aware of that would prohibit, let's say, ASRM starting a larger fund for to contribute to more fellowship programs if it was funded by pharmaceutical companies or genetic testing companies or others? Is there anything that prohibits that?
Not to my knowledge, but I'm not an expert in that area. So I would probably defer to somebody from ASRM or SREI to answer that question.
I'll save that question for next time. I have Dr. Robbins on the show as the first question he's getting ambushed with next time. So when you talk about having more fellows per fellowship program, you said you could easily do 2 a year, perhaps even more than that. You said that ACGME first needs to approve that. How hard is that? Is the only reason why people aren't doing more of that right now because of the cost, or are there other hurdles that ACGME puts forth other than cost to say, no, you can only have 1 fellow per year?
Yeah, I would say both. I would say probably the main impediment is cost, but there are significant challenges to trying to increase what we call the complement of fellows. The ACGME wants you to demonstrate that you have sufficient clinical resources and research infrastructure to train that additional fellow. And sometimes they can be picky. So, you may think that you have the capacity to train additional fellows. The ACGME might not agree. So I think that is a challenge for some fellowships. That's something that we could advocate for, within the field of REI. But I would say that probably the answer is both.
Well, you've walked us through quite a bit about how a fellowship program gets off the ground, what we could do to get more REI fellows and more REI fellowship programs, viewing them as part of the same problem, but 2 different questions. How would you like to conclude on this issue?
I would say that you're asking an excellent question at a very relevant time. I think we are at a crossroads in the field of REI. We know that the demand for what we will be doing is going to be increasing exponentially. We know that there are challenges that come with that type of growth. And we know that there are going to be many different changes, both in terms of technology and in terms of who provides care. I think at the heart, being an REI physician means that you have significant understanding of the reproductive system and are able to implement changes and innovation in how we provide infertility services. I don't think the role of the REI is ever going to go away. I think that we just need to work very creatively to expand the number of fellows that we're training without sacrificing that level of training, and incorporate REI trained physicians into a larger team in order to provide excellent care for our patients and hopefully adapt to the needs of the future.
Dr. Rachel Weinerman, REI Fellowship Program Director at University Hospitals. Thank you very much for coming on Inside Reproductive Health.
Thank you so much. It's been a pleasure being here.
You've been listening to the Inside Reproductive Health podcast with Griffin Jones. If you are ready to take action to make sure that your practice thrives beyond the revolutionary changes that are happening in our field and in society, visit fertilitybridge.com to begin the first piece of the fertility marketing system, the goal and competitive diagnostic. Thank you for listening to Inside Reproductive Health.